There's a $14 gap that's tearing apart something we all depend on. $14 might not sound like much, maybe the cost of 2 coffees or a cheap meal. But this particular $14 difference is exposing cracks in a system that 33 million Americans rely on to survive. Here's what's happening. Medicare Part B premiums just hit $185 per month in 2025. That's the highest they've ever been. Meanwhile, Social Security checks went up by just 2.5%. Do the math, and many retirees are actually taking home less money than they did last year, even though their benefit technically increased. The gap I'm talking about? It's between what the government says inflation is running at, around 2.5%, and what seniors are actually experiencing at the grocery store, the pharmacy, and the doctor's office. One number says things are getting better. The other number says they're getting worse. And millions of people are caught in the middle, watching their purchasing power evaporate month after month. We're going to break down exactly what's causing this disconnect. You'll see why the official inflation numbers don't match what's happening in real life for people on fixed incomes. We'll walk through the actual dollars and cents, where the money's going, why it's disappearing faster than it should, and what this means for anyone approaching retirement or already living on Social Security and Medicare. This isn't just about numbers on a spreadsheet. It's about understanding why the system that's supposed to protect our most vulnerable citizens is starting to buckle under its own weight. Let's start with what just happened in January 2025. Social Security recipients received a 2.5% cost of living adjustment, or COLA. For someone getting the average retirement benefit of about $1,927 per month, that means an extra $48 before we account for anything else. $48. That's what the government calculated would help seniors keep pace with rising costs. But here's the immediate problem. Medicare Part B premiums jumped from $174.70 in 2024 to $185 in 2025. That's an increase of $10.30 per month, or about $124 per year. For most people, Medicare premiums are automatically deducted from Social Security checks. So right off the top, before that money even hits a bank account, more than 20% of the COLA increase disappears. That brings the actual increase down to about $38 per month for the average beneficiary. $38 to cover 12 months of higher costs for everything else: food, utilities, gas, housing, medications not covered by Medicare, dental care, and all the other expenses that don't stop just because you're retired. Now, the government says inflation is running at around 2.5%, which is why they set the COLA at that level. The Bureau of Labor Statistics tracks something called the Consumer Price Index for urban wage earners and clerical workers, the CPIW. That's the official benchmark. According to this measure, prices across the economy rose by about 2.5% over the measurement period from the third quarter of 2023 to the third quarter of 2024. But there's a fundamental problem with using CPIW to calculate Social Security increases for retirees. The CPIW tracks spending patterns for working-age people who are employed, earning wages, and spending money differently than seniors do. Workers spend proportionally more on transportation, clothing for work, and dining out. Seniors spend proportionally more on health care, prescription drugs, and staying in their homes. Some economists have pushed for using a different measure called CPIE, the Consumer Price Index for the elderly. Studies show that if we'd been using CPIE instead of CPIW over the past few decades, Social Security benefits would be noticeably higher today. The difference compounds over time because healthcare costs, which seniors spend more on, have consistently risen faster than general inflation. Between 2000 and 2023, healthcare costs increased by roughly 120%, while overall inflation rose by about 73%. That gap matters enormously when you're trying to survive on a fixed income. Let's get specific about what seniors are actually facing at the checkout line and the pharmacy counter, because this is where the official inflation numbers and lived reality diverge sharply. Grocery prices have been particularly brutal. Even though the rate of increase has slowed from the peak inflation period of 2022, prices haven't come back down. They've just stopped rising as quickly. A dozen eggs that cost $1.50 in early 2020 were running $4 to $6 in many markets by late 2022. They've come down some, but they're still dramatically higher than they were just a few years ago. Ground beef, chicken, bread, milk, staples that seniors rely on because they're on tight budgets, all remain elevated. Fresh fruits and vegetables, which doctors tell seniors they should be eating for their health, have become almost luxury items. A retiree in rural Pennsylvania told a local news station she stopped buying fresh produce except for occasional sales, relying instead on canned vegetables because she simply can't afford fresh anymore. That's not an isolated story. Then there's housing costs. Even for seniors who own their homes outright, property taxes keep climbing. Insurance costs have spiked, particularly in states like Florida and California, where climate-related risks have caused insurers to either raise rates dramatically or pull out of markets entirely. Home maintenance and repairs don't get cheaper when you're older. If anything, they become more urgent because delaying them can lead to bigger, more expensive problems. Utilities are another major expense. Natural gas and electricity prices have been volatile, and many seniors live in older homes that aren't as energy efficient. Running the heat in winter or air conditioning in summer isn't optional for people with health conditions. A senior with respiratory issues can't just tough it out through a heat wave to save money. But the category that really exposes the gap between official inflation and reality is healthcare beyond what Medicare covers. Medicare Part B covers doctor visits and outpatient care, but it doesn't cover everything. Dental care? Not covered. Vision care beyond certain screenings? Not covered. Hearing aids, which millions of seniors need? Not covered by traditional Medicare. These aren't frivolous expenses. They're fundamental to maintaining quality of life and independence. A single root canal can cost $1,000 or more out of pocket. Cataract surgery, even with Medicare covering part of it, can leave a patient with bills of $3,000 to $5,000 depending on the specifics. Hearing aids run anywhere from $1,000 to $6,000 per pair, and they typically need to be replaced every 5 to 7 years. Prescription medications are another massive burden. Medicare Part D covers some drug costs, but there's complexity with deductibles, coverage gaps, and formularies. A retiree taking medications for diabetes, high blood pressure, and cholesterol, a very common combination, can easily spend $200 to $400 per month, even with Part D coverage, depending on the specific drugs prescribed. So we've established that the numbers don't match reality. The question is, why? Why is this gap growing instead of shrinking? What's actually broken in the structure of how we support retirees? The first crack in the foundation is how Social Security COLA is calculated. We touched on this earlier, but it goes deeper. The CPIW measurement period runs from the third quarter of one year to the third quarter of the next year. That means the COLA announced in October for the following year is based on data that's already several months old by the time it takes effect in January. If prices spike in the fourth quarter or early in the new year, that increase won't be reflected in benefits for well over a year. You're always playing catch-up, and when inflation is moving quickly, that lag can be devastating. There's also the question of what gets measured in the index itself. The basket of goods and services tracked by CPI doesn't perfectly reflect what seniors actually buy. Housing costs in CPI use something called owner's equivalent rent, essentially what homeowners could theoretically charge if they rented out their homes. That's an abstract concept that doesn't capture real property tax increases, insurance hikes, or maintenance costs. Healthcare is another area where the methodology creates distortions. Medicare premiums themselves aren't included in the CPIW calculation, which creates an absurd situation. The government uses CPIW to determine the COLA, then immediately takes a chunk of that increase back through Medicare premiums, which aren't reflected in the inflation measure that determined the COLA in the first place. The second major crack is in Medicare's financial structure. Part B premiums are calculated to cover about 25% of program costs, with the remaining 75% coming from general tax revenues. But healthcare costs have been rising faster than general inflation for decades, which means that 25% share represents an ever-growing absolute dollar amount. When Medicare costs surge, whether from expensive new treatments, an aging population requiring more care, or simple medical inflation, premiums have to rise to maintain that cost-sharing ratio. In years when Social Security COLA is low because measured inflation is low, but healthcare costs are spiking, you get exactly the squeeze we're seeing now. There's also increasing complexity and cost in the healthcare system itself. Hospitals and healthcare providers are consolidating into larger systems with more pricing power. Pharmaceutical companies continue to charge whatever the market will bear for essential medications, particularly in the United States, where drug price negotiations have been extremely limited until very recent legislative changes. Administrative costs in the U.S. healthcare system are among the highest in the developed world. All of this filters down to what Medicare has to pay for services, which then affects what premiums need to be to cover program costs. The third structural issue is something economists call shrinkflation and skimpflation, phenomena that official inflation statistics often miss. Shrinkflation is when package sizes get smaller, but prices stay the same or increase only slightly. That bag of coffee that used to be 1 pound is now 12 ounces. The ice cream container that was half a gallon is now 1.5 quarts. Prices per unit are rising faster than the sticker price suggests, but CPI doesn't always capture this. Skimpflation is when quality decreases, cheaper ingredients, less service, fewer features, while prices remain stable or increase. These degradations in value erode purchasing power in ways that don't show up cleanly in inflation data. For seniors on extremely tight budgets, these shifts matter enormously. They're price takers with no negotiating power, and they can't just earn more income to offset rising costs. When the system fails to keep pace with real costs, seniors don't just accept it quietly. They make painful adjustments that ripple through their lives and often through their families' lives as well. The most common adjustment is cutting back on food. Studies of food insecurity among seniors show that millions regularly skip meals, buy cheaper and less nutritious food, or go to food banks to stretch their budgets. The AARP reports that food insecurity among people over 60 has increased significantly over the past several years. This isn't just about being hungry, though that's bad enough. Poor nutrition in older adults leads to faster cognitive decline, increased fall risk, longer hospital stays when they do get sick, and higher mortality rates. Cutting food costs to save money ends up creating expensive health problems down the line. Another common adjustment is medication rationing. Seniors cut pills in half, skip doses, or don't fill prescriptions at all because they can't afford both medications and other essentials. The American Heart Association has documented that medication non-adherence due to cost is a significant factor in worse health outcomes for chronic conditions like heart disease and diabetes. When someone doesn't take their blood pressure medication consistently because they're trying to make it last longer, they're dramatically increasing their risk of stroke or heart attack. When a diabetic skips insulin doses to save money, they're courting serious complications. These aren't theoretical risks, they're documented patterns affecting millions of people. Housing becomes precarious for many seniors facing this cost squeeze. Property tax relief programs exist in some states but not others, and they often have complex application processes that confuse people or exclude them based on technicalities. When seniors can't keep up with property taxes, insurance, and basic maintenance, they face impossible choices. Some end up moving in with adult children, which can strain family relationships and finances. Others downsize to smaller, cheaper housing, but the costs and logistics of moving can be prohibitive for people in their 70s and 80s. Some simply stay in homes that are deteriorating around them, creating safety hazards. The emotional and psychological toll is significant but harder to quantify. Financial stress accelerates cognitive decline in older adults. The constant anxiety of not knowing if you can pay your bills, afford your medications, or keep food on the table takes a measurable toll on mental health. Depression rates among seniors struggling financially are substantially higher than among those with adequate income. Social isolation increases because people can't afford to go out, drive to visit friends or family, or participate in community activities. That isolation in turn worsens both mental and physical health outcomes. For those who still have adult children able to help, the squeeze often extends to the next generation. Middle-aged Americans find themselves caught between supporting aging parents and saving for their own retirement, funding their children's education, or paying their own bills. This financial sandwich pressure affects millions of families. You might be thinking this is primarily a problem for current retirees. And yes, they're experiencing it acutely right now. But this structural breakdown affects everyone, whether you're 35 or 65 or anywhere in between. First, the demographics are unavoidable. The baby boom generation is aging into retirement en masse. By 2030, all boomers will be 65 or older. That's roughly 73 million people who will be relying on Social Security and Medicare. The ratio of workers paying into these systems versus beneficiaries taking out is shrinking. In 1950, there were about 16 workers per Social Security beneficiary. By 2010, that ratio had fallen to about 3 workers per beneficiary. By 2035, it's projected to be around 2 workers per beneficiary. This isn't a temporary blip, it's a fundamental demographic shift. The Social Security Trust Fund, under current projections, will be depleted by around 2034. That doesn't mean Social Security will disappear entirely, but without changes, it would only be able to pay out about 77% of scheduled benefits based on incoming payroll taxes. That's a massive cut that would devastate retirees. Medicare faces similar long-term funding challenges. The Hospital Insurance Trust Fund, which pays for Part A, is projected to be depleted by 2031. Again, that doesn't mean Medicare vanishes, but it means major adjustments will be necessary. If you're currently working and paying into these systems, you have a direct stake in whether they'll be there for you and whether they'll provide adequate support. The structural problems causing today's $14 gap aren't going to fix themselves. They're going to get worse unless something changes. Second, the broader economic implications affect everyone. When millions of seniors don't have enough income to meet basic needs, that reduces consumer spending across the economy. Retirees who can't afford to go out to eat, travel, buy new appliances, or spend on anything beyond bare necessities represent lost economic activity that affects businesses, employment, and tax revenues. There's also the healthcare cost spillover. When seniors can't afford preventive care or medication, they end up in emergency rooms with acute crises that are far more expensive to treat. Those costs get passed through to everyone in the form of higher insurance premiums and higher healthcare costs overall. Third, there's a fundamental question of social contract and moral obligation. We set up Social Security and Medicare as a promise you work and pay in for decades, and when you retire, there's a safety net to ensure you can live with dignity. If that promise is eroding, if people who did everything right find themselves unable to afford food and medicine in their 80s, what does that say about us as a society? This isn't about politics or ideology. It's about whether we maintain the basic systems that allow people to age without falling into poverty and desperation. So, what can actually be done? The problems are structural, which means they require structural solutions, not just minor tweaks or temporary patches. One frequently discussed reform is switching the COLA calculation from CPIW to CPIE, the inflation measure specifically designed to reflect elderly spending patterns. This wouldn't be a complete fix, but it would more accurately capture the real cost increases seniors face, particularly in healthcare. Legislation to make this change has been introduced multiple times but hasn't gained enough traction to pass. The main objection is cost. CPIE typically runs higher than CPIW, which means COLA increases would be larger, costing the government more money. But if the goal is to actually maintain purchasing power for retirees, using the right measuring stick seems fundamental. Another proposal is to increase Social Security benefits across the board, either through a general increase or by adjusting the formula to weight more heavily toward lower earners. Various plans have been floated, including increasing the bend points in the benefit formula or adding a minimum benefit level to prevent anyone from falling below a certain income threshold. These changes would require additional funding, which brings us to the revenue side. Social Security payroll taxes currently apply only to earnings up to a cap, which is $176,100 for 2025. Earnings above that threshold aren't subject to Social Security tax. Some proposals would eliminate or raise that cap, requiring higher earners to contribute more. Other revenue options include increasing the payroll tax rate slightly, bringing state and local government workers who aren't currently in the system into coverage, or dedicating other federal revenue sources to shore up the trust fund. On the Medicare side, reforms have focused on controlling costs within the healthcare system itself. The Inflation Reduction Act of 2022 gave Medicare the ability to negotiate drug prices for the first time, which should help reduce prescription costs over time. But the scope is limited to a small number of drugs initially, and the savings will take years to fully materialize. Broader healthcare reform, addressing hospital pricing, administrative costs, and the overall structure of the U.S. healthcare system would have enormous impact but faces significant political obstacles. The U.S. spends far more per capita on healthcare than any other developed nation while achieving worse outcomes on many measures. Addressing that inefficiency would benefit everyone, including Medicare. Some proposals focus on expanding Medicare coverage to include dental, vision, and hearing, which would reduce out-of-pocket costs for seniors, but would also increase program costs unless offset by savings elsewhere or additional revenue. There's also discussion of reforming Medicare Advantage, the private insurance alternative to traditional Medicare. Medicare Advantage plans have been growing rapidly, but concerns have been raised about aggressive marketing, coverage denials, and the accuracy of payments to these plans. Better regulation and oversight could potentially save money while improving care. For individuals facing the current squeeze, the immediate options are more limited but still important. Many states have programs to help with prescription drug costs, heating and cooling assistance, property tax relief, and food support. The challenge is awareness and accessibility. These programs often have complex application processes and aren't well publicized. Organizations like the National Council on Aging maintain databases of benefits programs that seniors might qualify for. Making an effort to identify and apply for these programs can provide meaningful help, even if it doesn't solve the underlying structural problem. Family conversations about finances, care needs, and planning become increasingly important. Many families avoid these discussions until a crisis forces them, but proactive planning can identify problems early and create more options. If you're still working and years away from retirement, the clearest takeaway is that you cannot rely solely on Social Security and Medicare to provide comfortable retirement. That's not how the system was designed. It was meant to be a foundation supplemented by personal savings and pensions, though traditional pensions have largely disappeared. Maximizing contributions to 401s, IRAs, and other retirement savings vehicles is crucial. Starting early makes an enormous difference due to compound growth. Even small amounts saved consistently over decades can build substantial retirement assets. Understanding healthcare costs in retirement and planning for them specifically is also essential. Health savings accounts, if you're eligible, provide tax advantages for setting aside money for future medical expenses. Long-term care insurance, while expensive, can protect against catastrophic costs if you need extended care. That $14 gap we started with, the difference between what inflation supposedly is and what it feels like when you're trying to survive on a fixed income, represents something much larger than arithmetic. It represents a system under strain, demographics that are shifting faster than our institutions can adapt, and millions of people caught in the middle trying to maintain dignity and independence while the ground shifts beneath them. The fixes aren't simple, and they're not cheap. But the cost of inaction is steeper than the cost of reform. Every year we delay addressing these structural problems, they become harder to solve and affect more people more severely. For the seniors experiencing this right now, cutting medication and skipping meals aren't abstractions. They're today's reality. For workers who expect these systems to be there when they retire, the trajectory we're on isn't sustainable. Understanding the actual numbers, the real gaps, and the structural causes is the first step toward demanding meaningful solutions. This isn't about accepting decline as inevitable. It's about recognizing what's breaking and insisting it gets fixed before the breakdown becomes complete. We've built these systems before: Social Security in the 1930s, Medicare in the 1960s, during times when the political will existed to tackle big problems. The question is whether we still have that will, or whether we'll watch the $14 gap keep growing until it becomes a chasm that swallows millions of our fellow citizens. The numbers tell a story. We just have to decide if we're willing to listen and do something about what they're saying. If you found this breakdown valuable and want to stay informed about economic shifts that affect real people's lives, make sure to follow What Happened After. We dig into the stories behind the numbers and the human impact of policy decisions. This is the kind of analysis you won't find in typical news coverage. We go deeper, connect the dots, and always ask what actually happens to people when systems start to break down.